9. We'll get started on time and finish on time. All right. Welcome everyone to Geriatric Medicine Grand Rounds. Our speaker today, as is tradition, is one of our geriatric medicine fellows who chose a topic that she's interested in and is going to share with us today. So Dr. Elyce Opheim, go ahead and get started. I'm excited to hear your talk.
Good morning, everyone. My name is Elyce. I'm one of the geriatric medicine fellows, as Kate said. I wanted to talk to you guys about a problem that's pretty common in the population of patients that we see, which is oropharyngeal dysphagia. So what I'm hoping to cover today, let's see if I can get this view to go away. Sorry. Just manage. Sorry about that. So things that I'm hoping to cover today are reviewing the pathophysiology of oropharyngeal dysphagia, talking about diagnostic evaluation and interventions, and then considering sort of how we counsel patients, older patients and their caregivers, even before we send them for diagnostic testing. Let me ask, Diane, do you have any idea how I can get rid of these screens on the side so that I can show people my full screen?
I'm sorry, what are you trying to get rid of?
The pictures on the side. Are you guys seeing that as well?
We don't, we only see your slides. It looks
Oh, great, perfect, then never mind. Okay, moving forward. So part one is talking about some of the pathophysiology of dysphagia. So I wanted to sort of start with a case. This is an 88-year-old gentleman that I saw at Harborview earlier in the year. He had a history of type 2 diabetes, hypertension, cognitive decline that was sort of not otherwise specified. He was admitted for 2 medical issues, for an acute upper GI bleed and then suspicion for Fournier's gangrene. He underwent debridement of the Fournier's gangrene and then remained intubated for about 2 days after that procedure to allow time for colonoscopy and endoscopy. And then when he was extubated, he was actually found to have suffered a post or peri-procedural or post-operative stroke. And then his clinical course was further complicated by prolonged agitated delirium. He had a post-extubation swallow evaluation, and that showed that he was high risk for aspiration, particularly in the context of his delirium, because the stroke hadn't yet been discovered at that point. And the recommendation was made that he be NPO. And this is just a quote from the speech language pathologist's note that said that they anticipated further progress with ongoing neurologic recovery, recommended a VFSS or video fluoroscopic swallow study when he had improved candidacy for oral intake on clinical bedside evaluation. So I was taking a step back, thinking about dysphagia. First, definition. This is difficulty moving a food bolus from the mouth into the esophagus. It affects about 13% of the general population over 65, up to 47% of frail elderly patients admitted to the hospital for acute illness. And then patients with dysphagia are 33% more likely to be transferred to an acute care facility rather than returning to their own homes. This affects more than half of elderly nursing home patients. And then there's a statistic out there that up to 68, almost 70% of nursing home patients with dementia may have silent aspiration, meaning sort of there's no clinical evidence of them aspirating, but it is happening. And then there was one large cross-sectional study of nursing home residents, and in those residents experiencing dysphagia, their 6-month mortality was almost 25% compared to 12% in those patients without dysphagia. So it's a pretty significant issue. Thinking about signs and symptoms, this includes coughing while a patient is trying to swallow. They may have nasal regurgitation of food. They may have a wet vocal quality after swallowing. Probably heard sort of a garbled sounding voice in some of your patients before. They also may have poor management of their secretions, a weak cough, and if they're able to sort of tell you, they may say that they have a sensation of food getting stuck. So thinking about, there are a number of normal changes with aging that just sort of predispose this population to dysphagia. And this falls under an umbrella term of presbyphagia, which we can think of as sort of an old but healthy swallow, in air quotes. So commonly older adults experience decreased oral moisture. They have reduced taste and smell sensations. They may have sarcopenia, which is reduced muscle mass, strength and connectivity elasticity. They might have poor dentition. They might have poor denture fitting. They might have decreased oral hygiene. This all leads to a decreased range of motion, reduced chewing efficiency, slower swallowing speeds. This increased the risk of having residue in the mouth after swallowing. They also might have an increased risk of upper airway invasion, meaning the food and liquid is going where it's not supposed to. Then you add in some sort of stressor or comorbidity. So for my patient, this was an acute GI bleed and a possible serious infection with underlying medical conditions, and that leads to increased susceptibility to dysphagia with some of the downstream complications, including malnutrition, pneumonia, dehydration, increased morbidity, mortality, and hospital readmissions. So it's sort of this major cascade that comes, that just increases in risk with aging. So thinking about the mechanics of swallowing, I wanted to take you guys through this. Hopefully you can see my mouse here. So up on the upper left is the first phase. This is the oral preparatory phase. This is mastication or chewing. This is where the food bolus is mixed with saliva, which contains amylase. This is all under voluntary skeletal muscle control. On the upper right, we have the oral transport phase. This is where the food that's been chewed is collected into a cohesive bolus. It's propelled toward the pharynx. So the tongue goes up against the hard palate here and then propels the food back toward the pharynx. Then on the bottom left, we have the pharyngeal phase. This is where the tongue continues to press up against the hard palate to propel the food bolus into the pharynx. This is partially under voluntary control and partially involuntary. You have velopharyngeal closure up here, sort of closing off the nasopharynx. You have the tongue base retracting against the posterior pharyngeal wall, sort of continuing the wave of the front of the tongue pushing against the hard palate all the way to the back toward the pharynx. You have movement of the hyoid bone and the larynx to allow closure of the airway at 3 levels, including where the epiglottis contacts the arytenoid cartilage. You have contraction of pharyngeal muscles, and then the upper esophageal sphincter opens. And then the last phase is the esophageal phase, and I'm not going to spend a lot of time on that, or really any time on that today, but this is where you have peristalsis that helps to contract in a coordinated way to move the food bolus down the esophagus, and this is under involuntary control. So I have a video just because me talking you through the swallow is not necessarily the same as seeing an animation of it. So give me just a moment to get this in the right timeline. And this is something that was put together by the free medical education. Let's see, here we go.
The swallowing mechanism. Let's begin by reviewing the physiology of the swallowing mechanism. It is generally divided into 3 phases. Oral phase, in which the food is chewed and lubricated to form a bolus. Pharyngeal phase, in which the movements of the soft palate, larynx and epiglottis separate the air passage from the food passage so that food and drink are not aspirated into the nose or trachea. Esophageal phase, in which the food passes down the esophagus via peristalsis into the stomach. A disruption in any one of these phases could result in dysphagia, and difficulty in the pharyngeal phase especially could lead to aspiration.
We'll pause that there and we'll come back to that. So then thinking about some of the pathophysiology at the brain level, this image is from a paper that was going over some fancy devices to try and help with dysphagia. So try and ignore the black lines here, these electrodes. It was mostly the best schematic I could find of how the brain and central nervous system is involved in this. So there are signals that come from the cortex and the subcortical areas. They go through this brainstem swallowing area. And then we have involvement of 6 cranial nerves, multiple spinal nerves. We have peripheral sensory and motor innervation in the oropharynx. So, you know, the muscles of the tongue and sensation in the tongue, some of which is from the cranial nerves. And then we also have sort of olfactory sensation. So there are a lot of different levels of the nervous system that are involved in this. Some studies have shown that generally there is left lateralization of the oral phase of swallowing and then right lateralization of the pharyngeal phase. So we have involvement of both hemispheres in this coordinated movement. And then thinking of some examples of issues that occur at the brain level that we see commonly. So stroke is one of those. The stroke sort of disrupts this neural network and it causes decreased activation of both the affected and unaffected hemisphere. And then when patients have recovery of their swallow dysfunction, it actually represents compensation and reorganization of the unaffected hemisphere. Contrast that with ALS, where you have bilateral damage of the upper motor neuron. There's no possibility of compensation, and so you get a progressive decline in cortical activation as the disease progresses and worsening dysphagia as well. So thinking about complications, I think we all worry about this top one, aspiration pneumonia or pneumonitis. And some of the downstream consequences of that include the potential for needing ICU level of care, prolonged hospitalization, risk of delirium, risk of hospital-acquired infections, prolonged functional impairment. We also can think about dehydration or hypovolemia, and some of the consequences there include dry mouth, decreased oropharyngeal hygiene, and then oropharyngeal colonization or infection. Going hand in hand with that is malnutrition. Thinking about downstream consequences of that include sort of delayed rehabilitation, loss of muscle mass, and then sort of getting into this progressive cycle of continuing to lose muscle mass and then worsening of dysphagia, which leads to worsening frailty. Also associated with that is weight loss overall. And then something we may or may not think about quite as often, but that really impacts our patients is reduced quality of life and avoiding meals. So if someone is, out in the community and they're worried about puffing or choking in front of their friends, they might participate in meals less, and that leads to increasing social isolation. And we all know there are many consequences of that. So I wanted to define a couple of terms. So within this picture, the circle in each is where the vocal folds are. This is sort of a side view. This is where the mandible is in both pictures. And then this is the oropharynx and then the cervical spine on the right. So the top picture demonstrates what's called penetration. This is where the bolus enters the laryngeal vestibule, but it doesn't move below the true vocal folds at the level of this circle to go into the trachea. Whereas aspiration is where the food bolus enters the laryngeal vestibule and actually does bypass the vocal folds and gets into the trachea and the airway. The normal response to this is to cough or clear our throats. We've all done this without even thinking about it, but that normal response doesn't always happen. Okay, so thinking about part 2, diagnostics and what do we do about this problem? Things that we might ask our patients can start with sort of a general question of what happens when you try to swallow. Do they have frequent throat clearing, regurgitation of food, any difficulty chewing, prolonged chewing, which might be something that a caregiver notices. A caregiver might also notice that there's more food left over on their plate. And do they have any evidence of dysarthria? You can also think about impacts of various medications. The first one of which geriatricians are never a fan of, which is anticholinergics. Those can lead to both dry mouth and impaired cognition, among other things. Neuroleptics can also impair the pharyngeal phase, and then opioids actually can suppress the cough reflex. So then on the next few slides, I'm going to cover sort of a detailed evaluation that a speech and language pathologist might do. This is using a handout from the med to share with me. So there'll be a lot of information. I'm walk you through all of it on sort of like have sort of a more general evaluation, looking at, how is the patient behaving? Are they awake? Are they obtunded? Do they have reduced attention? Are they agitated? You can look at the pattern of their motor speech. So is there dysarthria? Do they have no obvious problems? And there's some more detailed descriptions that you can get into there. Do they have any changes in their language? What does their voice quality sound like? Is it wet? Is it breathy? Is it hoarse? And then you can kind of make note of any other physical exam findings that you note. And then going through some of the cranial nerve involvement here. So the trigeminal nerve has both motor and sensory involvement. For the motor portion, you might have patients open and close their jaw against resistance. You might see if they can lateralize their jaw. This is testing a number of muscles, including the temporalis, the masseter muscle. If patients have problems with this, they might have reduced mastication, more difficulty in preparing the bolus, among other things. You can also check out the sensory component to this. You can test their light touch to their cheek or the anterior 2/3 of their tongue. And if they have reduced sensation here, it might make them unaware of oral residue or put them at increased risk of anterior leakage, which is where the food or liquid bolus comes back out their mouth, sort of out through their lips. Thinking about the next cranial nerve is the facial nerve. This is purely motor. So you're testing whether patients can puff out their cheeks with air and hold it against compression. You can see if they can smile for you, if they can protrude their lips with some light resistance. You're testing a number of things, including the orbicularis oris and some other facial muscles that are sort of involved in the mouth function. If they have problems with this, they might have a leakage of the bolus anteriorly. They might have increased residue sort of in the lateral sides of their cheeks. The glossopharyngeal sensory component here, this is the tongue involvement. So you might see what happens when you place a tongue depressor sort of at the posterior pharyngeal wall. Being careful because patients may or may not have a gag reflex. You can also have them wrinkle their brow just to test this. You're testing involvement of their stylopharyngeus musculature. And then if they have issues here, they might have some pooling before they swallow, and they might have delayed initiation of the swallow. The vagus nerve, there's sensory and motor components to this. For the motor component, you want to have them say ah, and then note what their voice sounds like. It tests a number of muscles, which are all listed here. I will spare you me reading those all to you. But you might hear secretions on the vocal folds. They might have reduced glottic closure, which leads to a weak cough. And then for the sensory component of the vagus nerve, this is the reflex cough. And so if they have issues with that, they might have reduced sensation in their pharynx, which would lead to residue and no cueing to clear that residue. And then getting into the pharyngeal plexus. So this is glossopharyngeal and cranial and the vagus nerves or the pharyngeal branch. You might have them, you want to see what their palate does when they open their mouth. You can also, this is testing a number of these muscles, including the levator veli palatini, which takes me back to med school anatomy days. Have issues with this, they might have decreased sort of diffuse residue across the pharynx, and they might actually have decreased opening of the upper esophageal sphincter as well. And then thinking about some of the sensory components here, if you can test light touch to the posterior third of the tongue, see if they have a reflexive cough. If they don't have those things, then they might have reduced sensation in that area, which leads to increased risk of residue. And then one more, and then we're done with this portion. So thinking about the hypoglossal, this is a motor cranial nerve involvement. It's mostly focused on the tongue. So you have them stick their tongue out, pull their tongue back into the mouth, see if they can move the tongue side to side, up and back. You might look for fasciculations in their tongue. This tests the intrinsic tongue muscles, the styloglossus, the hyoglossus. If they have problems with this, it means that they're having more trouble manipulating the bolus within their mouth in the preparation and the transfer phase. They might have increased oral residue, increased pooling in their mouth, and then they may have, it may reduce the amount that the posterior tongue is able to push against the posterior pharynx, among other things. Okay, so back to this video. Let me get us to the right portion here. This is just going over some of the different types of imaging or diagnostic studies we might be getting. We'll focus on just a few of them, but I thought this was a nice summary.
The investigations specific for dysphagia are fiber optic direct laryngoscopy, which can view the laryngeal inlet and is useful for investigating patients of orophagia, which patient is given a radio opaque contrast to drink, and the contrast is then X-rayed as it passes through the pharynx and esophagus. Video fluoroscopy is similar to barium swallow, but instead of still images, a video clip is made of the contrast passage into the stomach. It is considered a better study than barium swallow. Esophageal endoscopy. This is particularly useful in patients with esophageal dysphagia, in which a structural lesion is suspected. Esophageal manometry. In this test, a catheter is passed into the esophagus, which measures the pressure along the length of the esophagus. This is useful in patients in which a motility/propulsive cause of dysphagia is suspected.
Excuse me. So thinking about some of the diagnostic images that we see, particularly on the inpatient setting, two of them I wanted to focus on. One of them is a VFSS, or video fluoroscopic swallowing study. This is sort of the traditional gold standard. The patient swallows boluses that are laced with barium or oral contrast. They can do various viscosities. And then excuse me, the VFSS is an X-ray video basically of how they're swallowing. It's taken at 25 frames per second, and it can help determine if aspiration occurs before, during, or after the swallow response. One study, which was a retrospective study of skilled nursing facility patients, found that aspiration on VFSS predicted rehospitalization, but did not predict pneumonia or death from pneumonia. So this will get to some of the evidence base that I'll get to a little bit later. I think one of the things to note about VFSS is that it requires the patient to be able to travel to the radiology suite. They have contrast fees. This is where a flexible endoscope is inserted through the nose into the upper pharynx. The patient eats and drinks food and liquids of varying bolus size and consistency. It's a portable exam, so it can be done at bedside. It uses real food and liquid and doesn't use any barium or contrast, but it is a longer duration of study. This can actually be used in biofeedback mode, which can be helpful for some patients as they're sort of progressing through their therapy. It can also be better for patients with really severe dysphagia who haven't eaten for weeks or months. But it does require the patient to be able to tolerate an endoscope pass through the nose, which might be relevant for a patient with agitated delirium, for example. And it also carries with it some risk of bleeding. So I wanted to show you, this is sort of this is what we would see with a VFSS, or the video fluoroscopic swallowing study. So I'll orient you here. Here's the hard palate, here's the oropharynx, the jaw here with teeth, obviously, and then down here is where the level of the vocal folds are. I will put some labels in there so that you can see that. Just wanted you to be able to see the plain image without all of my text all over it. So you have the nasopharynx, the oropharynx, the hypopharynx, where the esophagus meets the pharynx here, which is called the pharyngoesophageal segment. And then the esophagus down here, as you can see, the trachea is more anterior, the esophagus is more posterior, and then we have the C-spine here for orientation. So keeping that in mind, I have a video of, this is a normal VFSS, and it'll look like the same image over and over, but it's actually the patient is progressively swallowing thicker and thicker substances. So, so bear with the video. So you can see there's sort of the mandible here, there's their teeth. This is sort of the nasopharynx, the oropharynx, and the hypopharynx here. Right about here is the level of the vocal folds for them. And then this is the epiglottis right about there. I think right about here is where we start to get much thicker substances. And so the swallow is a little bit slower, so you can kind of perceive some of the changes that are occurring. It's sort of hard to see, but with the epiglottis right here, you get, with a normal swallow, you get complete inversion of the epiglottis in order to protect the airway up here and allow the food bolus or liquid bolus to pass directly into the esophagus. Eventually, they start gulping liquids, which might be right about now in short order. And then here, I think they're just drinking water. So you sort of get the idea. And then we'll compare that with an abnormal study on the next slide. This one is short, so I'll play the video twice. You can see there's sort of, if I can pause it and maybe go back, just because it's so short. You can see there's sort of some pooling of liquids here in the mouth, sort of not collecting everything into one. The contrast substance, the liquid, goes down into the oropharynx and the hypopharynx, and you get some spillage, and you actually can see some leakage anteriorly into the trachea, which would be aspiration. So I'll play that one more time just because it's short. Okay. So then just an anatomy reminder for the flexible endoscopic swallow study, or the FEES, that I'll show on the next slide. This is borrowed from Netter's anatomy, and it's sort of an inverted view of what we're maybe used to seeing, because this is the view that we'll see on the FEES. So starting at the top, this will be where the esophagus is. We have the trachea here in the middle, which is protected by these true vocal folds in white, and then the false vocal folds in pink here. I will point these out on the FEES as well. You have the epiglottis here, which is sort of this U-shaped structure, and then the base of the tongue, just at the base of this picture. So then, pulling up our FEES video, let me get this into the right. This is a long video, and I'm not going to show you the whole thing. Just skip ahead. So pausing here, let's see if I can get rid of this. Let's see. So up here is where the esophagus is. Here are the false vocal folds. And then down here, this white structure here is the esophagus, or sorry, the epiglottis. And then just below that, it's sort of down at the base of the image is where the base of the tongue would be. Okay, there is sound associated with this, but it's not essential to hear it. So you can see sort of dynamic movement of the vocal folds. This is up where the epiglottis is here.
Okay.
And then at some point, the patient will start swallowing green milk, which is what you're seeing now. So you can sort of see dynamically what's occurring when they're swallowing. And if you can perceive it, this epiglottis here is inverting with each swallow.
And how about a few gulps? Like
And then this is the base of the tongue again. So that's where he swallows a couple of things of milk, a couple of gulps of milk in short order. So we've gone through all of our diagnostic evaluation. We have an abnormal swallow. Now, what do we do? So forgive these pictures. The photos are not meant to make light of dysphagia. It's mostly just, they were sort of the best demonstration I could find of positioning. So some postural changes that we might think about for our patients, these are compensatory techniques. So they're meant to sort of reduce or minimize symptoms of dysphagia without actually changing the underlying physiology. So patients might do a head tilt if they have difficulty propelling the bolus toward the posterior pharynx, they might tilt their head up toward the back of their pharynx. Alternatively, if they have unilateral laryngeal dysfunction or unilateral pharyngeal paresis, such as in the case of a stroke, they might turn their head toward the damaged side in order to compensate for the inability to move that side of their pharynx. And then they also might use a chin tuck maneuver, which is probably the most common one that we've all thought about for our patients. This is something they can do if they have reduced laryngeal closure, if they have reduced motion at their tongue base, especially posteriorly, or if they have a delay in triggering the pharyngeal swallow. Other sort of compensatory techniques that we could think about include good oral care. It actually has some evidence behind it. And then kind of slowing the overall rate of eating, which you might need to rely on caregivers to help patients remember that. You can also think about texture modification. This is something that we commonly see, especially in the hospital setting. And the concept is a nice one. It's sort of the idea is to make the swallowing process slower, which means that it's theoretically safer. Unfortunately, there's not a lot of evidence behind this. It's all sort of low quality and inconclusive. So I think it's important to acknowledge this in conversations with patients and families. Thickened liquids have been shown to decrease the frequency of dysphagia on VFSS in one study, but it was also associated with higher rates of dehydration and lower quality of life. Which leads into the next point, which is that there's sort of mixed adherence to thickened liquids. They're not that pleasant. I think in person, we could have maybe tried some thickened liquids. Many of you may have done this in the past, but I think it's something that's worth thinking about for our patients. And then there's also the risk of dehydration, as I just said, and reduced caloric intake overall. There were studies in cancer patients and Parkinson's patients that showed sort of low quality evidence for whether changing textures actually has any impact on aspiration. So back sort of in the 2000s or so, there wasn't really any standardized way to thicken liquids or foods across medical settings, across states, and even internationally. So in 2013, the IDDSI, or the International Dysphagia Diet Standardization Initiative, was established. And the goal was to develop a new international standardized set of terminology and definitions to describe texture modified foods and thickened liquids for all individuals of all ages, in all care settings and all cultures. And so they made this, this sort of hierarchy ranking, so it's sort of a continuum of 8 levels from 0 to 7. And I'll take you through some of this. Drinks can go from 0, which is thin, just like water, to up to 4, which is extremely thick. And then foods can be from level 3, which is liquidized, all the way up to level 7, which would be regular or at least easy to chew foods. And so they have numbers associated with them. They also have colors associated with them, and they have text labels. So it was a way to sort of standardize this so that across a lot of different care settings, we have something to refer to help guide us and make sure that we're doing this in a standard way. So I didn't want to pull up pictures of every single one, but I thought that these ones were helpful just to get an understanding of the thickness that we might be thinking about. So level 0 is thin, it flows like water. Level 1 is called slightly thick. It requires a little bit more effort to drink than water. but can still be drunk through a straw. Level 2 is called mildly thick. This sort of flows off of a spoon and it's sippable. Then getting into where I thought that it was helpful to see a picture. So level 3 can still be drunk from a cup, but it sort of might drip slowly or have dollops or strands through the slots of a fork, for example. Level 4 is called pureed or extremely thick. And this sort of sits in a mound on top of the fork. You might have a little bit flow through and maybe form sort of a short tail below the fork. It doesn't flow or drip continuously through the fork prongs. It's usually eaten with a spoon and can't really be consumed from a cup. Level 5 is called minced and moist. We're getting into the food category now. So this is small lumps, and they've actually defined a width. So in adults, it's no more than 4 millimeters in diameter. And there's a different definition for pediatrics. But I thought that this picture was actually a nice demonstration of it. So here on the left, you can see that the food piece actually fits between the prongs of a fork. And that's how you can make sure that it's the right size. On the right here, you can see that the food cannot fit between prongs of a fork, so this is not small enough. Level 6 is called soft and bite-sized. This can be mashed with pressure from a fork, and it does require some chewing. So they actually have instructions such as that the thumbnail blanches to white when mashing the food, and that the food does not return to its original shape when pressure is released. And then level 7 is easy to chew. So these are sort of everyday foods with soft textures. They're supposed to break apart easily with the side of a fork or a spoon. And the example they gave was actually a piece of fish that sort of flaked really nicely when So what else do we have to offer our patients? We can offer them rehabilitation. This is through a lot of times through the help of our excellent speech and language pathology colleagues. There are a couple different maneuvers that I just wanted to show a picture of. This first one is something called a supraglottic maneuver. So you have the patient inhale, hold their breath, swallow, cough, and then swallow again. There's something else called the effortful swallow, which is sort of demonstrated here. You have the patient press their tongue against the roof of their mouth as hard as they can, and then swallow as hard as they can. Related to that is the Mendelssohn maneuver, so that the picture sort of represents it the best. So you have them start their swallow, pushing their tongue against the roof of their mouth, hold at the halfway point for about 5 seconds, and then complete their swallow and repeat. And that's sort of more of a, I think the concept is more of a strengthening exercise. And then lastly is the Masako maneuver. This is where the patient sticks their tongue out between their lips. They use their teeth to bite the tongue very gently. They swallow while they're holding their tongue between their teeth. And all of these exercises have been shown to benefit swallowing related outcomes in multiple patient populations. No talk on dysphagia for geriatricians would be complete without a note on feeding tubes. I think we are all pretty well aware at this point that feeding tubes, while they may be able to deliver nutrition in someone who cannot swallow in a coordinated way, it doesn't do anything to redirect oral secretions. And feeding tubes come along with the risk of complications, including pneumonia, colostomy tube. You can also have reflux of gastric contents, GI bleeds, agitation, discomfort. There was a study called the Food Trial. This is in patients with acute stroke, and they compared swallow function, recovery of dysphagia for patients who had a stroke if they placed an NG tube immediately at admission or waited a week. And actually many patients recovered their swallow function within a week after their stroke, such that they didn't need nutritional support with a feeding tube. I'll note that in patients with really significant dysphagia and dementia, their survival is equally short, about 6 months, whether or not a feeding tube is placed. And as we all probably know, the Choosing Wisely campaign and AGS recommend against feeding tube placement in patients with moderate to advanced dementia. So how do we counsel our patients and their families? We'll bring it back to our case. So this, again, was the 88-year-old gentleman, history of diabetes, hypertension, cognitive decline. He was admitted for an upper GI bleed and suspicion of Fournier's gangrene, underwent surgical debridement, had a post-operative stroke, brief intubation, really prolonged delirium, and he had an abnormal post-extubation swallow evaluation. So thinking about, even before we send someone for a VFSS or a FEES, I think what we should do is share with the patient and caregiver what we hope to gain with that diagnostic evaluation, as well as discussion of possible recommendations, like recommending that somebody be NPO, discussion of the possibility of a feeding tube, maybe even before we send them for diagnostics. If the patient has dementia and you happen to be seeing them in an outpatient setting, it's really, I think it's a really good idea to talk to patients and caregivers about the possibility of developing dysphagia, and probably use or the dementia roadmap to help sort of guide some of those discussions. I think, talking with patients about this before going for diagnostic evaluation also gives us an opportunity to sort of explore the role of food in family dynamics and family culture and in the patient's joy. I think a lot of people are very distressed when the swallow function is not working very well, and caregivers are distressed when they're not able to feed their loved ones. And so it's worth a conversation sort of before we do all of this workup sometimes, at least to give some anticipatory guidance. I think another thing that's important to do is acknowledging the relative lack of evidence for all of our compensatory strategies and texture modification, to say, we think that this helps. We don't actually have a lot of evidence for it. And then I think it's important to enlist the help of our speech and language pathology colleagues to help guide families on what to expect, both with the actual diagnostic studies and then potential recovery. Our SLP colleagues are incredibly experienced and often involved in complex conversations about sort of next steps when dysphagia is really persistent. So I think it's really important to enlist their help. So summarizing my case, so this gentleman ended up having an NG tube that was placed for nutritional support. This was sort of a multi-pronged recommendation. The surgical team was really worried about his wound recovery, and they were concerned that his agitated delirium was worse because he was hungry. He ended up having to be placed in restraints. He managed to pull his NG tube almost every day, sometimes multiple times a day, despite these restraints. The palliative care team actually intervened to get the son permission to be at bedside for really restricted, and so most patients did not have visitation privileges. Eventually, after he pulled his NG tube multiple times, he finally refused to have it replaced. Over this time, he had frequent speech and language pathology visits. He ended up having both FEES, so that bedside evaluation with the endoscopic camera, and then later he had multiple video fluoroscopic swallow studies. And over the 6.5 weeks that he was admitted after extubation, he did progressively improve to the point where he actually discharged on a level 5 minced and moist solids, and actually was able to drink thin liquids by teaspoon only. And then he discharged to the post-acute care setting. So that is about all I have for you today. I wanted to say a big thank you to Dr. Amy Hirano for connecting me with Jasmine Christensen, who's one of our excellent speech and language pathologists at Harborview, who was able to help me with the videos that you saw in today's presentation, as well as the MedBridge handout for sort of detailed evaluation of patients with dysphagia. I want to thank the Harborview Speech and Language Pathology team. These are my references. And then if anyone has questions, that is also the QR code for evaluation.
Elyce, this is May. That was excellent. Thank you. When at AGS, the speech pathologist who ran that session where we all did the test, drank water. I think that's where I got COVID. But anyway, I am wondering, she advocated for us having a clear-cut goals of care discussion before even consulting speech language path. And in my experience, I have had the speech language path immediately, at least on the outpatient side, immediately order tests before even talking about just like what the patient wants. So I guess what I'm trying to say is that they're finding that they, both on the outpatient and the inpatient side, and it varies with institutions, that there's no clear-cut discussion on what the patient's parameters are for what the findings will be. And I'm just wondering if there should be more of a policy about that before we consult our colleagues who are extremely busy.
Yeah, I think that's a really good point. You know, when I was talking with Jasmine about this, she said, you know, it's sort of in evolution as we speak, and that there's sort of a change within the culture, at least of the Harborview team, to think a little bit more about goals of care before going immediately to imaging. I think like many things in medicine, it may take some time to become sort of a culture shift. And so I think this is where it's sort of up to us as individual practitioners and as a group, particularly a group of educators, to sort of emphasize the importance of this and, you know, sort of take it upon ourselves, at least until it becomes more of a standardized criteria. You know, I wonder if it could even be part of like the referral that you put in Epic. You know, have you had any sort of goals of care conversation? It might be worth integrating that.
Hey, this is Angela. So nice presentation, and I really enjoyed the videos. Also, never apologize for showing dogs. That's the other thing. So I love the dogs. Yeah, I'm on the nutrition committee for Harborview, and I'm just wondering if there's any QI project or anything we can, you know, drum up or do, or have them do, you know, to look at like, hey, if we put people on strict diets, you know, can we collect some level lab, or, you know, and we can maybe brainstorm offline, but, you know, this just seems like something really suited for the nutrition committee, because they sort of look at all sorts of outcomes for patients. So hit me up if you have ideas.
Yeah, will do. Absolutely. That's good to know.
And just kind of to reflect on that, I mean, they're really early, like advocates for like early feeding in the ICU and all that kind of stuff too, you know, so like, you know, making sure we're doing the right thing for the right patient at the right time, all that good stuff.
I think there are things in the chat. Oh, Dr. Hrana says, Jasmine's amazing. Thank you, Dr. Hrana.
Is there, listen, I have another question. You know, some of the maneuvers that seem to make sense. I guess what I struggled with on the outpatient is that I've asked for speech language path consult for dietary modification and maneuver and swallow maneuver education, and I get a response saying they're going to get they're going to get the imaging studies first because that's the way they're triaging it right now. And I'm saying, well, they don't want imaging studies, they just want some ideas, but maybe they can't have ideas on speech modification or maneuvers, swallowing maneuvers, until they get the imaging study. And so I find myself going around and around. I'm just wondering, are any of those maneuvers, I had heard that some are inappropriate or potentially dangerous, and I'm just wondering, is that, I couldn't find evidence of what that means, like chin tuck, for example, which seems like one of the easier ones for our patients.
Yeah, it's a good question. I don't know that I have the answer to it, other than that, you know, if there is, you know, something like silent aspiration, you're not necessarily going to see that on a bedside swallow eval. So like the patient whose case I used as the vignette for this presentation, he had, suspected aspiration because he kept sort of clearing his throat on exam. And then it turned out when they did the video fluoroscopic study, he actually wasn't aspirating and the throat clearing wasn't correlated with anything. So I think there are sort of limitations to a clinical evaluation, and that's where they get a little bit more detail from something like a VFSS or a FEES that can help sort of tailor the recommended exercises or compensatory techniques based on what they're seeing. But it's a good question for our SLP colleagues. I don't know the answer.
This is Annie. I don't know if you can hear me. May, in response to your question, and just in general to keep in mind at Harborview, which most of us already know, but the speech language department has had a lot of their therapists leave. So just, I think it's across the board, COVID, a lot of people have left the field and especially have left Harborview. And so there's a lot of new grads. And so Jasmine has been trying to, I think, mentor a lot of the newer speech language pathologists, but a lot of them have been trained with liability in mind. So any sign of dysphagia or aspiration, and they're saying NPO. And so a lot of what she's worked on is trying to temper that a little with, well, let's think about what they can do and what they can do with maybe a modified diet. And so her approach is based on years of experience. And I think a lot of the newer grads that if you are running into difficulty, I think having that level of kind of clinical knowledge based in experience, that might be part of it, because Jasmine very much thinks through things very with a lot of the patient and family in mind, thinking about like what can they do, what is maybe the least invasive approach if this is a patient who really does not want invasive studies. So she would then opt for maybe the VFSS instead of the FEES, or instead of other things like just automatically defaulting to a recommendation for considering an NG tube and NPO. So I think part of what we're seeing is that, some of the older, more experienced, wiser speech pathologists are turning over, and we have to really try to, I think, preserve the institutional knowledge and wisdom of some of the more experienced practitioners, but that's something that they're all struggling with too in that department.
Oh, Annie, that is such an important point. And I would like to channel that with the experience Ruru and Yi and I are having instituting this mini help protocol. We are just constantly reminded that a huge percentage of our staff in the hospitals are very new or are travelers, or just very junior in their approach to patients, and especially the complex older patients. So yes, that's a very important reminder across all staff levels right now. Thank you.
It almost seems like we would benefit from having someone like Jasmine, who works specifically with our older adult patients, or actually acts as a mentor, or works with our service in particular to mentor us, or to teach us. But yeah, I mean, there's something to be said for specializing within a field, right? We're geriatricians, we specialize in this older adult population. It's not unreasonable to think that having specialists within the field of speech language pathology for the geriatric population would result in better care for that population as well. Just specialists within specialists.
I think it's hard to overestimate how significant these conversations are for older people and their families, just around the changes in ability to eat and nutritional decline over time, and preferences around what they're really willing to accept. And everything from tube feeding to changes in dietary texture to weight loss and changes in quality of life are just such fraught conversations for many people. And so one of the big overlaps is working as a team to have these conversations timely, and just recognize that we're all trying to work through this difficult situation together. And I've just developed a more humility about how challenging these conversations are over time, and not to be so dogmatic about what I think the right answer is to these questions.
Yeah, I totally agree. Thank you, Dr. Grunwald. I think, part of my thought process is just to start the conversation with patients and families, before we're going for diagnostic imaging, so they don't come back with an NPO recommendation and it's like a total surprise and shock and really distressing for the family. So I think they are very intricate and heavy conversations sometimes. And so I think starting them and starting to develop that rapport and that trusting relationship with the patient and family is really important.
Great. Well, thank you, Elyce, for such a fantastic presentation, and thanks to all of you and Elyce for this really great conversation. I think the combination of the two helped us all get a lot out of this, and I think there's still a lot of work to do in the clinical setting. But thank you. This was so comprehensive and touched on all of the important points. So congratulations on a great presentation.
Thank you.
At 9 o'clock, we have our annual program evaluation of the fellowship for geriatric medicine